Good afternoon, ladies and gentlemen. It gives me great pleasure to welcome you all to this episode of FOGSI ICOG Guru Mantra program. We have had very successful programs right from January, and this is our fourth episode. May I now request Dr. Lakshmi Srikhande, Chair ICOG, to welcome you all and deliver the ICOG chairperson's address. Nilima, PPT.
Let it be, Sarita. So, good evening all, and I am so happy as ICOG chair to start this FOGSI ICOG Guru Mantra web series, and so happy to have Dr. Usha Saraiya as Guru for this Guru Mantra web series. I know, madam, you are Guru's Guru, because I was lecturer way back in 1992 at Kama and Elbles Hospital when you were unit head and the honorary professor at Kama and Elbles Hospital, and you have taught so many residents, lecturers, and not only I learned academics from you, but I learned humility and so many life skills from you. So you are a real mentor to we all. And of course, everyone knows your passion for cervical cancer because you are instrumental in starting that cytology clinic and Kama and Elbles Hospital. And I have seen your passion and how you are nurtured and nourished this cytology clinic. So at ICOG, we are so happy to learn about this cervical cancer. I know talks about squamous cell carcinoma, and you have chosen to talk about adenocarcinoma of cervix in this Guru Mantra web series. So welcome, madam. And at the same time, thank you so much on ICOG's behalf for accepting our invitation. What to say about convener, Dr. Sarita Bhalerao. Month after month, she's coming out with a wonderful program and gurus and the experts for this Guru Mantra web series. And now Dr. Sheila Mane has also joined as co-convener for this Guru Mantra web series. Today, I also welcome our experts, Dr. Bhagyalakshmi Nayak and Dr. Shalini Rajaram, to provide their expert comments on this topic, that is adenocarcinoma cervix. So I also welcome all the delegates and attendees who have logged in to learn from Guru's Guru, Dr. Usha Saraiya. So happy learning. Welcome all for this web series, and I hand over back to Dr. Sarita for further proceedings.
I'd like to now welcome our experts. We have with us Dr. Professor Bhagyalakshmi Nayak, who's the head of Department of Gynaecology at AHPGIC Cuttack Medical College. She's had a very successful tenure as the chairperson of the Oncology Committee of FOGSI 2018 to 21, where she has done path-breaking work in the area of cervical cancer screening and prevention. And one of the programs I remember very much is the Northeast Doctors Program, where she really trained doctors to, for cervical cancer screening. She's also a governing council member of ICOG. She's the vice president of AOG in India and the honorary secretary of the Association of Gynaecologists of India. She has a strong academic interest and is the assistant editor of the Indian Journal of Gynaecology and a peer reviewer of the Indian Journal of Surgical Oncology. And she has delivered many prestigious orations, including the Dr. Abha Singh oration in Raipur. And when I asked Dr. Bhagyalakshmi, I said, just tell me, how did you become a gynaecologist? And she said, I finished my MS, and then I went to Delhi and I worked in the cancer hospital in AIIMS. And that's how I became a gynaecologist. So welcome, madam, and thank you so much for joining us. We also have with us Dr. Shalini Rajaram, a very well-known gynaecologist who's worked in the city of Delhi and now has moved to a very prestigious appointment at the All India Institute of Medical Sciences in Rishikesh. She is the professor and program coordinator for the MCH program in GYN oncology. And she has written many books. She has many awards to her credit. And I must say that she is organizing the AOGIN conference in Rishikesh in September, and she has invited everybody to join in this conference. So welcome to our experts. I'd like to now request Dr. Sheila Mane, Madam, to please introduce our guru for this afternoon.
Thank you, Sarita. Thank you, Lakshmi. And I think it's my proud privilege to introduce Madam. All of us, we know Madam, and I think as Lakshmi said that she learned a lot, but I think our association, because of FOGSI and ICOG, I think we have really learned a lot from you, Madam. And I still remember your orations where you have shown that how you have gone from village to village and spreading the message and getting the women screened. I think really the torch was, you started it, and I think we are yet to achieve whatever you have started, but I think now we have to really gear up. And I would like to thank Dr. Lakshmi for bringing in this topic, because even what I have learned in Bangalore also now, that in urban areas now the adenocarcinoma is on the rise. And the problem is that we cannot diagnose it early, and we really face challenges. And I think we have none other than Madam Usha Saraya, at least, I mean, as Lakshmi said, Guru ke Guru. So, Namaskar, Madam, aapko. And I would like to introduce her. All of us we know, but I always appreciate, this introduction, particularly in webinars, because we come to know so many things. When we are in big halls, we don't concentrate, but when we are in webinar, we are sitting in front of the screen, and we really come to know the achievements, which really motivates us, that the people are working so much, working so hard. So Madam is a senior consultant at Preach Candy, Saifi and Elizabeth Hospital, Mumbai. She's a founder member and past chairman and past president of ICOG. She started cytology clinic at Kama Hospital in 1970, developed it to an internationally recognized center. International awards, she has been conferred on honorary fellowship by RCOG in 2012, Award of Living Legends by IFCPC in July 21, Leadership Award for Preventive Oncology by CEPOC in 2022, and Outstanding Woman Obstetrician and Gynecologist at FIGO 2003. National Award, Lifetime Achievement Award by AOGN India in September 17, Lifetime Achievement Award by FOGSI in January 2020, and Dr. P.N. Wahi Award for ICMR in 1993. Madam is a past president of MOGS, FOGSI, ICOG, IAC, and AMWI. And she is a chairman of Ethics Committee for Clinical Research of NIRRH and ICMR in 2011 to 2018. And Madam, thank you, and over to you for your deliberations. Thank you.
Thank you.
Thanks. Yeah, I'll just thank Dr. Sheila Mane, and thank you, Madam, for joining this program as a convener. Your expertise will definitely make this program much better and richer than what it already is. Over to Dr. Usha Saraya.
Thank you very much. First, I must thank all of you present here for saying such kind words about me and my work. It's been 50 years ago that I started, and I feel I'm still so much interested and so happy to see the progress that that country has made. And I'm happy to participate in whatever programs that all of you arrange. And you're all such brilliant organizers and doing so much for the academics in India. ICOG has taken the lead and this year has really outshone in academic events. And so has FOGSI, with myriads of activities, millions of programs, and the whole country is absolutely involved in academic activities. So it's my pleasure to be here today and to give you a talk on adenocarcinoma cervix. I hope you find it interesting. I was wondering what subject to select, because we are addressing really a large group of ICOG fellows and members and the FOGSI membership. Many of them are not really doing oncology, but would like to know something more and may begin to start taking an interest in this field. So I did not want to go into very technical issues, but I also wanted to sort of emphasize on the practical aspects of the things. And as you know, I'm so interested in history that I will have to say something about where we were 50 years ago and where we are today. So the topic I have given is adenocarcinoma cervix, increasing the challenges. And since it's a Guru Mantra program, I thought I'll say a few words about Guru-Shishya relationship. It's a very important relationship and it is an eternal bond. It is not a contract. And on Guru Purnima, many students send greetings to their Guru year after year. And this is a custom which both Guru and Shishya value very much. And another aspect of the relationship is that a Shishya of today becomes a Guru of tomorrow. The Guru inspires the Shishya to love teaching, love education, need to spread education, and in turn, when the Shishya grows up, is following the steps of the Guru and is happy and comfortable to teach youngsters. Now, there is another aspect of it. Many people think that it is a very Indian tradition or feel that it is all originated in India. Well, maybe it did do that, but let me tell you, it is an English word listed in Oxford English Dictionary, and it is an elder respected teacher. And I used to be a visiting professor in Poland, and I was very surprised and happily surprised that they have a very strong Guru-Shishya relationship. And their professors were respected so much. And when the professors were going to retire, I was invited to the inaugural programs and the inaugural conferences, and I saw how much they meant to felt the need to be one with the teachers and respect them and show them love and affection. So they used to always say, respect and honor your Guru because he has shared his knowledge with you. You can share many things, you can share gifts, you can share belongings, but it's not the same as sharing knowledge. Now, I have gurus of my own, and this is a photograph of mine with Dr. C.L. Javeri, who was the founder president of ICOG, and Dr. M.N. Parikh, who was the founder secretary of ICOG, and I was a founder fellow. And at the first induction, at the first convocation, which was held in AICOG Mumbai 1985, this was the photo taken, which I have cherished. And this is a flower of a bouquet of flowers, a basket of flowers, as my tribute to my old gurus. And they were the gurus for ICOG as a whole. Now, this is another aspect of the Guru story, that how did we all get interested in preventive oncology? We have to understand that it was due to Papa Niccolo and Hinselmann. They were born in the 19th century, but their major work was in the 20th century. They were separated by the Atlantic Ocean. Those days, there was no means of communication, and they worked independently. And sadly, their work was totally affected or almost came to an end due to the Second World War. You know, world events are so responsible for what is happening in the scientific world. And everything was at a standstill till the war got over, and then the whole story was taken up again. And it was WHO in 1967 who declared that cervical cancer is a preventable disease. And that was the beginning of preventive oncology. There was no such a science or discipline before that. And they announced that you must diagnose and treat at pre-cancer level. Then there will be no mortality and no invasive cancer. And it was just 60 years ago, not a long time ago. And we've made tremendous progress in these 50 years. And from control, we have come to the topic of elimination of cervical cancer. But still, there are increasing challenges. Challenges do not ever end. So I would like to share with you one of my early publications. In 1998, I published an article on the multicentric origin of HPV and its relationship to CIN. You know, in the end of 20th century, when Zurhausen introduced the papilloma virus etiology of cervical cancer, we knew so little about the disease. How does it affect a person? What is the clinical appearance? What is the clinical progression of the disease? Very little was known. And we all who were working on it, we collected data, we collected cases, and I wrote in the summary, a large epithelial surface of the lower female genital tract is exposed to the sexually transmitted HPV, and the lesions are frequently multicentric. So there is a rise in incidence at present in adenocarcinomas, as all of you have experienced. Maybe an apparent rise because squamous carcinoma is eliminated at CIN level. Also, we use two modalities. What we do is triaging or co-testing, PAP plus HPV. Then, of course, detection is always higher with two modalities. Then glandular and squamous can coexist also. We may diagnose squamous, but we may miss the glandular because we think it is normal to have glandular cells. Now, hopefully, let's always think of the positive side that all this knowledge and the HPV vaccine will bring down the incidence. So maybe another 50 years, this topic will not be even discussed. Now, HPV infection, particularly infection with HPV 16 and 18 and 31 and 35 or both, is the primary risk factor for adenocarcinoma in situ and associated cervical cancer. So I've traced here how it happens. There is a normal uterine histology with the endocervical cells, single level columnar cells with an intact basement membrane surrounded by stroma and very, very complex glandular structure is affected by 16 and 18 HPV. It will lead to adenocarcinoma in situ. You can see in this slide on the right side is normal epithelium and on the left side is the in situ carcinoma. And if not detected in time, will eventually progress to adenocarcinoma. This is the life history of the disease. How common is it? These are European figures, 6.6 per 100,000 overall. And if you take the peak age group of 30 to 39, that's a very young age group, I would say, the women in their childbearing years, when there is a lot of metaplasia in the epithelium. Epithelium is very active and dynamic, and it is exposed to 16 and 18. The incidence can be as high as maybe double, 11.2 per 100,000. So this age group, you have to be extremely careful when you are screening. And of course, there are diagnostic difficulties for glandular lesions. Glands, as you can see here, are a cluster of cells. They overlap each other. Nuclei look very peculiar at the sides, and in the center, they are different and more difficult than to diagnose squamous cell carcinoma. Now, how do you classify these conditions? There are many, many classifications which are in vogue or which are in practice. I've just compared two, the RCOG classification, which we were using most of the time, and now the WHO has a modified classification, but they are similar. There are 3 grades: pre-cancer, in situ cancer, and invasive cancer. Whatever you call it, that's your decision what to call it. RCOG calls it low-grade cervical glandular neoplasia, whereas WHO says endocervical glandular dysplasia, or EGD. The next high level is high-grade cervical glandular neoplasia by RCOG, HCGIN, and here it is called adenocarcinoma in situ. Then the third one is, of course, endocervical adenocarcinoma by RCOG, and WHO calls it adenocarcinomas and says it could be any of these 5 usual: biloglandular, endometrioid, neuroendocrine, and glassy cell. Now, I've had a glassy cell carcinoma in Kama, and we have reported that case. They are rare cases, but if you are vigilant and you get a case, please always report it. We would like to know how many cases we get. Now, another very important one is called SMILE lesions. They are really very interesting group of cases. And this is stratified mucin-producing intraepithelial lesion. Now, these arise from reserve cells between the squamous and glandular. They start in the transformation zone, but all cancers, we say, start in transformation zone. But it is a malignant transformation of a metaplastic cell, neither columnar nor yet fully squamous. And in that, both glandular and squamous elements are present. So SMILE lesions are what we should look for and suspect. Now, who started this story of SMILE lesions? I want to tell you about Adolf Staffel. Many of you may have met him. He has come to Bhubaneswar. I don't know whether Bhagyalakshmi has met him. He lectured many times in Delhi and Mumbai. And in 1975, before even HPV was known, he said that metaplasia, it can be physiological, and that is normal transformation zone. And it can be atypical metaplasia, where it occurs in an abnormal transformation zone. So the normal transformation zone, it becomes eventually well differentiated squamous cell carcinoma, squamous epithelium. We don't have to worry. But the atypical one, if there is the host response is good. Mind you, before we knew about HPV, we knew about host response. We said that those women whose host response is good, they will not get into a malignancy. But if the host response is poor, then any carcinogen can overcome the immune response. So if host response is not inadequate, then it will go from dysplasia to carcinoma in situ to invasive cancer. And imagine this was known in 1975, but we were still looking for the carcinogen. And next to Staffel is a person called Westby. I had written an article also in Jogi about Westby and his contribution. He was a contemporary of Hinselmann, and he looked after Hinselmann's work, and he had lots of stories to tell us about the work they did. Now, there are skipped lesions. In the whole of the genital tract, all the epithelium doesn't have the same amount of immune response. So there are some areas which are susceptible and become malignant or become pre-malignant, and there's some skipped lesions. So this adenocarcinoma can go upwards into the endometrium, or it may come out downwards and cover the ectocervix. That is what we have to know, that it not always covers ectocervix, it may go upwards also. Then the stromal reaction is very important. There is edema and marked inflammation, and it is what we call desmoplastic stroma. You know, stroma is not normal. We always say epithelium is abnormal, stroma is normal, but not in this case. It is stroma is also abnormal. And there is marked structural complexity to the endocervical epithelium. You all know how complex it looks. And if there is lymphovascular space involvement, then prognosis is adverse, not a good thing to have. There's another system also called Silva system, which I think our oncology friends might be familiar with, but we don't do much with it because it's a pathological classification, histopath based, and risk stratification is also given. It's worth knowing about it. Now I come to the a video presentation, and this video is done by Miniello and me and based on our books. There is a cytological diagnosis. No, sorry, we have got this. We'll just get that again. Yeah. So it begins with a cytological diagnosis of glandular abnormality. Maybe 3 to 4% of the smears may have that. It will go to adenocarcinoma in situ if it's undetected. And if it's untreated, it will go to adenocarcinoma. Now, colposcopy of adenocarcinoma in situ is very important to know, very important to understand. It looks like a normal ectopy or a normal erosion, often confused with immature metaplasia and very easily mistaken for cervicitis. And they're variable sizes and irregular shape. Now, let me show you some of these pictures. Now, here you can see it looks like a normal erosion. Maybe you'll say glandular epithelium is seen and things like that. But it may not have the aceto-white rim that you are looking for. There may be dense aceto-white lesions surrounded by glandular epithelium. Then there are coalescing papillae and a variegated red and white lesions. Let me show you this. See this dense aceto-white lesion in the middle. There is no white line up there, no white aceto-white rim, and it's surrounded by glandular epithelium. Now, what is coalescing papillae? The papillae are really very small, tiny papillae that you can see lower down, but above you can see the large papillae and they're joining together. This coalescing papillae is suspicious. And variegated lesions, you can see here, there is various shades of red you can see. Another thing is the vessels. We all know we look for abnormal vessels in green filter. Atypical root-like hairpin vessels, large cleft openings and cuffed cleft openings is what you are looking for. Here are some root-like vessels. They come from the base, you feel. And large cleft openings, I'll show you, they're really huge. This is the opening of an endocervical gland. Can you see how huge it is? It's largely white and cuffed. It's outlined. The cuffs are very white. Now you start suspecting it could be adenocarcinoma. How will you suspect that? Colposcopic features are similar to in situ carcinoma, but more pronounced, very prominent they are. Densely white to milky after acetic acid. And that strange yellow-white color is there, yellow-orange cover. You can see there is widespread milky appearance. And here you can see coalescing papillae. All over they're coalescing and forming big papillae. And here is a milky white lesion. No vascular pattern you can see underneath because it's too thick. At the periphery, you see some vessels and you can maybe make a diagnosis. Here's a skipped lesion. You look as if there are pouches of epithelium sprouting in the endocervix. And they all become dense white after acetic acid. And we know that something suspicious is going on in this epithelium. And this, I think all colposcopists know, when you see this, that you are worried that this yellow-brown color, yellow-orange color of the epithelium surrounding the normal epithelium is very suspicious. And you have to evaluate the cervix before using acetic acid, because once you put acetic acid, you may not see. So there are papillae of various sizes, large and fused, copious mucus production. You wipe it clean, still mucus is pouring. You wipe it again, it's still pouring. Here, can you see, this is an endocervical lesion staring at you from endocervix. And mucus production is unbelievable. It's pouring mucus because they are mucus secreting glands. And if you get purulent mucus and blood bands coming from out of the external os, you know something dangerous is happening in the endocervix. Now, hemorrhage and necrosis on the surface, we all know, we see a growth like this. You try to swab it with a swab holder and the tissue will come on your swab. It is that friable. Surface nodularity and papillary appearance, you see and you are worried what is happening. Atypical vessels you see, again, bizarre caliber, must be going in for malignancy. And the lesion may be surrounded by normal papillae. So if you cursorily see, you will see the normal papillae. But if you study it, you will find all this. This is a friable polypoid lesion showing surface nodularity. And look at these vessels. This is a 28-year-old girl. Adenocarcinoma appeared in the form of a papillary lesion. Others would think it is just a polyp and may even ignore it. But you see abnormal irregular vessels like this and coalescing papillae, and you know we can't leave it alone. They come, the vessels, and they abruptly disappear. Where they go, where the blood goes, we can't make out. Atypical vessels with bizarre course like this, and you are worried. Now, the lesion may be surrounded by normal papillae. See, other biopsy areas, if you take, they are normal. But this one particular with bizarre vessels is abnormal. And you have to understand that pathology to know that you have to do something. Yeah, I think we go to the next. So what do you do when you have a case like this? Is a very, very difficult decision. The treatment is LETS and cold knife conization. This is according to WHO, and WHO prefers cold knife conization because we have to do it as a diagnostic, and in some small cases or small lesions and young girls, it may be therapeutic also. But you must know the length of the endocervix. You measure it carefully. You have to go right up to the, just below the endocervical sphincter. And you have to take a top hat type of cone to include adequate stroma. Margins have to be clear. So unfortunately, you have to take a big chunk of the stroma. And multiple sections have to be studied of the cone for the final diagnosis. And the final diagnosis really is more or less based on immunohistochemistry and P16 evaluation. But not everybody has this facility, but we have to look for it. So why WHO says CKC is better over LETS? Because there are fewer recurrences after CKC. And adequate treatment and close follow-up for young patients with AIS is allowed, permitted. You may take a decision based on her need for fertility preservation. But if margins are not clear or margins are involved and lymphovascular space involvement is positive, then recurrence is likely and you must warn the patient accordingly. And if by any chance it is not AIS and micro and early invasion is seen, please reassess the whole case and follow FIGO guidelines. And if young women are desirous of fertility, you don't have to disappoint them. You know, there is possibility of trachelectomy, and there are ART procedures nowadays, and IVF is possible, and embryo donation in a surrogate certainly gives better outcome than trachelectomy results. But you can discuss with the patient, and for further things, you can go to the guidelines. Now, if I can give you some take-home messages, colposcopy has a limited role. We don't really make a diagnosis, but we give high suspicion. And if you don't do a careful colposcopy, you will not get the suspicion yourself, and you will not warn the clinician, and there may be delay. That is why I say your responsibility is to have the suspicion in your mind and look for it carefully. Each colposcopist has to be vigilant and not miss warning signs. When in doubt, you take photos and discuss with your colleagues, because they are not so common, these cases. I'm sure the oncology department see more of them, but we don't. Treat the patient first and then prepare for the biopsy. Don't do biopsy on the first day saying, I'm seeing something abnormal and I'm going to biopsy. That's not the right way. You have to give antibiotics. You have to use pessaries. You have to clear the local infection. You have to check for HPV infection and HIV status. Very, very important to know these things before you do anything which might harm the patient. CBC, and many of them are anemic because they've been bleeding, and there'll be more bleeding when you do the procedure. And is she on any medication? Because there are some medicines which have undesirable effect on the epithelium. Pelvic sonography, and nowadays we rely more on MRI, is very necessary to know where the lesion is coming from or where it is going. And you be frank with the relatives and discuss your, doubts that you have, and don't prevent them from understanding that it is a little serious matter and they must take care of the patient. And you schedule a biopsy when all your data is ready. Leaf biopsies are better. You can take multiple leaf biopsies, not do a cone or not do this and just wait for diagnosis. You can do LETs if you like. Be prepared for hemorrhage because they bleed very heavily, and because you have to take so much of stromal tissue out. So you have facilities for stay sutures on the descending cervical branch. You can inject adrenaline. You can be prepared. And endocervical curettage also, I feel, is very necessary, and endometrial curettage also. So I think I have given you the insight into what this treatment may suggest or mean. The responsibility for treatment of precancerous lesions of the genital tract rests primarily with the gynecologist, in whom women have full faith and expect guidance from. And I feel gynecologists, they need not be fully trained oncologists only or be very familiar with all this, but they should have the basic knowledge so they can take a reference, do a reference, take an opinion, but you must not lose your patient. That is what I feel. After the treatment, patient should still come back to you for follow-up and long-term follow-up. So I would like to end by saying that you are the key person, and you must treat these lesions to the best of your abilities with the help of gynecologists, and don't lose track of the patient. Keep her in your follow-up and give her confidence that things will be fine and you will take care of her, whatever happens. So thank you once again for listening so patiently to my talk. And I hope I have added to your knowledge. I have added to your confidence that you can treat all these cases. And I hope you will learn that we work as a team. We need anesthetists, we need oncologists, we need surgeons, and we must all work together to help the patient recover from her illness. Thank you so much once again. And I'm very happy to have the experts who are my colleagues. They're very well placed in gynec oncology departments and very knowledgeable. And I would certainly like to hear their opinion about this subject. So thank you very much. And over to you, Sarita.
Thank you, madam. For such a deliberately, I mean, you have taken this topic, that is adenocarcinoma, and enlightened us, because it always we know the squamous cell carcinoma, but adenocarcinoma really needs attention, and you have given us a crisp presentation and exact take-home message for all of us. Thank you, and I think we have experts. I think they can really throw more light and enlighten us.
Before experts say, madam, you are really guru's guru. You made it simple to the core. I mean, I don't do that level of oncology practice, but you made it so simple. I mean, even a basic MBBS student can also understand what adenocarcinoma is, and your slides were so clear. And it was a very, very clear-cut take-home message. So thank you so much, madam. And now to the experts for their expert comments.
I think before that, we'll request Dr. Parag Biniwale. He's the Vice Chair, ICOG. Would you like to share your thoughts with us?
Thank you, Sarita. I will not comment on the subject because I'm not an expert. We have Shalini and Bhagya who are good at it. But just a word about Madam Saraiya. I owe my entry and growth in ICOG to Madam Usha Saraiya. When she was the chairperson, I was helping Dr. Sanjay Gupte, who was her secretary then. And that is how I got interested in ICOG. And Madam, thanks to your teaching, I should say, that I've reached this position of Vice Chair of ICOG. And I've observed you for last 20 years as an office bearer of ICOG and now as a past chairperson. And you have a soft corner for ICOG because it's probably like a child who has grown under your tutorage. Thank you very much for being here.
Well said, Parag. Yes. Madam is
Thank
there
you, Parag, for the nice words. It is you who had the potential, and I was just there to select a person who had potential. I could see it, and I said, you will be a devoted office bearer to ICOG, and you have contributed a lot.
Thank
so
you.
I'm happy that you joined us.
Dr. Bhagya Lakshmi, would you like to take?
Hello.
Yes.
Can you hear me?
Yes.
I think, thank you so much, madam, for I think the pictures also spoke volumes for you. And I think it was not you speaking the 50 years of your experience. So do we have any questions in the chat box? I think.
Yeah, till you are searching, I think Dr. Shalini, you can comment.
Yeah, I think I'd like to congratulate Madam for a beautiful talk, and those pictures, the resolution was beautiful. What is the colposcope you use, Madam? It's a binocular colposcope, or they're beautiful pictures.
Yes, thank
Very
you.
clear,
So much.
very clear, magnified.
Yes.
So it's a binocular colposcope. So basically, I wanted to add to Madam's talk that almost all squamous cell carcinomas are HPV dependent, and roughly 80 to 85% of adenocarcinomas are HPV associated. So you still have a few cancers which may not be HPV associated. So that's where your diagnosis is very important, because it's not that every adenocarcinoma is HPV associated, but 85% are HPV associated. And apart from and doing an HPV test is very important to pick up cancers. Apart from cytology, cytology can be used as a triage test, but having an HPV test is, I think, primarily important, because we know the etiology is HPV associated. They are the carcinogens causing HPV testing. So all of us should shift to HPV testing for screening. That's one thing I would like to add to whatever ma'am spoke. Ma'am spoke about vaccination. I think that would be the ultimate in eliminating cervical cancer, because adenocarcinomas are difficult to detect. You may miss it because a lot of times it is inside the cervical canal. It may be a small lesion that you may not pick up even with your colposcopy, because they are arising in the endocervix, like ma'am showed, in the glandular epithelium, and maybe not directly from the transformation zone. Or they may be higher up in the endometrium. A lot of adenocarcinomas of the cervix are carcinoma endometriums coming into the cervix. So they may be high up, so you may miss it. So you need to have, like ma'am said, colposcopy will give you a lot of information, but you need to have that high index of suspicion. You need to be able to, even on your clinical examination, maybe a slightly barrel-shaped cervix, looking absolutely normal from outside, but it is maybe a little hard and it is barrel-shaped. That will give you some other clues for adenocarcinoma. So all in all, I think squamous cell carcinomas may be easier to pick up, but like ma'am had beautiful of an adenocarcinoma, and so high index of suspicion is required, and because they behave very differently. The HPV-associated adenocarcinomas behave differently from HPV-independent adenocarcinomas. The treatments are also different, and we should understand that they are more aggressive, and they are seen a little later than squamous cell carcinomas, because they're lying inside the endocervical canal. So some tips, and Madam talked a lot about it, and WHO also has changed. Madam, from that last classification, they've again changed it in 2020. And now we just have HPV associated cancers and HPV independent cancers. And HPV independent cancers are the three types: that is gastric, mesonephric, clear cell, and endometrioid. So WHO keeps on changing. On 14, I think Madam had talked about the 18 classification. I think in 2020, it again changed. So only students are there just for them to know the change in classification. Otherwise, I think it was a beautiful talk and beautiful, and like ma'am's had years of experience. It shows in the talk, and we're very thankful to have Madam around. And we hope to see you at AOG in India in September. I was telling Dr. Sarita that we want to see you there, and we wish to see you there.
Yeah, thank you.
Yeah.
I think all of you are, very lucky to have excellent histopathology departments. In the medical colleges, that is not there, that dedicated histopathology and taking multiple sections and studying each one. And I would really think an ICOG tumor board meetings and colposcopy committee tumor board meetings are trying to fill that gap, because all this is based so much on what report you get. And all the time when you get reports of chronic cervicitis, then patients, the doctors say, why should we do any biopsies at all if that is happening? So I feel, many times when you have a suspicion, you have to also warn and say, please examine this carefully because I'm suspicious of something. So it is not that easy for us also to do that.
Yeah, so that communication between the gynecologist and the pathologist should be there all the time.
First of all, dedicated oncopathologists are not there in medical colleges. So some little cross-reference or some access to these things should be made available, so that for at least the important cases, there should be some way of getting a further discussion on it.
Yes, madam, because it's so important that we really need to discuss sometimes with your pathologists and give them with some pertinent clinical features, because
Yes.
actually giving a diagnosis from the blue is not easy. So if we give them some clinical features, like grossly how the cervix looks like, or maybe how it felt like when you did a biopsy. So these are some of the little things, the colposcopy findings, and if you have a HPV report, all of these need to be given to your pathologist. They cannot give you a report from the blue. So this is a thing, personal experience that we have all carried, that you need to discuss with your pathologist sometimes and communicate with them well, because as madam has very clearly told, that picking up adenocarcinoma is not a very simple thing. And as Dr. Shalini has told, that if we don't diagnose them early, the prognosis is also really guarded, because it has a lot of lymphovascular invasion, more of hematological metastasis as compared to squamous cell carcinoma, more of ovarian metastasis. So it's our duty also, when you find something suspicious, please talk to your pathologist. And if you're not happy, you can refer it to a center where it can be done at the earliest.
Thank you.
But sometimes the pathologists also, I've had one experience in UCMS when the patient had symptoms and I thought the cervix didn't look okay at all on colposcopy. And I think we did a bone biopsy also, and he says, I don't think it is malignancy. It doesn't look, and 1 year later, she comes back with a full-blown malignancy of the cervix. Yes. So things like that also happen. So I don't know what the solution is, or where the solution lies. So.
I think with this high resolution colposcopes,
yeah,
I think,
beautiful.
Yes, madam. The pictures were really, and the gland openings were really. They spoke for themselves. I think you don't need a histopathological diagnosis.
Dr. Shalini, but all histopathologists, they do give slides. So as a clinician, if we have any suspicion, we can always send those slides to another histopathologist for a second opinion.
And oncopathologist, I think if you have a doubt, you better send it to a specialized oncopathologist.
Yes, oncopathologist.
Very good people around here.
Bhagya was saying, during our MBBS days only, we are taught that whenever you are sending any sample for histopathology, we are supposed to write the clinical
Clinical
history and the findings so that pathologists can correlate.
Yes, but now the newer generation is missing on that.
Yes.
They will think about MRI and all those things and
I
not
know.
think
So
about
basic,
writing the clinical.
yeah, basic skills are really missing.
Yes.
Yeah. Is
But
there
there
any
are-
role of MRI?
Yeah, the role of MRI, Sarita, is when you have abnormal cells in your cytology. You can't see anything in a colposcopy. They're suspicious cells. Then an MRI can pick up even a 1 centimeter lesion inside the cervix or the endocervix. So MRI role, especially in postmenopausal women, when it is drawn up, and you can't do a cone in those cases because it's flushed with the cervix. So MRI is a very good tool to pick up a lesion. It is
Stromal lesions can also be picked up on
picked up. Yeah.
MRI. Vascularity is also important.
It's
And
so
as
important.
you said, Shalini, I'm very wary when HPV test is negative, and I find there is a suspicion. So, we must know as many as 15% can be
Negative.
negative and have abnormality. And
Right.
I think, Sarita, I'll remember one case we had of an ovarian lesion whose CA125 was totally normal. And they said CA25 is normal, then why worry about a small cyst in the ovary? And MRI revealed, CT scan, MRI, everything revealed that no, you can't leave this alone. And it was a early malignancy. So sometimes, you have to be little over enthusiastic to use these tests and say that I must determine what the lesion is. And patients also very unwilling to do more tests. They are not keen that you send from one test to another, but somehow it is in their interest to find out what it is. So we think that everything should fit, but all the tests don't fit in. And then we are not sure what the correct diagnosis is.
Yes, madam. Just one word, that when you are seeing a pap smear and your pathologist reports that there are glandular cells, and especially after 40 years of age. So I think those cases we have to be a little more careful.
Yes.
The shedding of glandular cells, especially after 40 years, we have to be careful that we are not missing out any glandular intraepithelial lesions or endometrial lesions.
Endometrial.
Symptoms of the patient also, they complain of mucoria, continuously sticky discharge. Then they in between there is a problem of bleeding episodes, unexplained bleeding. I think all these things are a little indication that something is happening.
Basically, don't ignore the patient's symptoms. But
Symptoms, yes. I
We
think
have
we
so
gather
many-
so much from the history, which people are really tending to forget about taking a history, a detailed history, because you get so many things out of that.
Yes, you're right. Just sitting and talking to the patient is important. Yeah.
Thank you very much. Dr. Lakshmi, would you like to say something before?
No, I am so happy with all the deliberations going on, and there are so many take-home messages for all the attendees from Dr. Saraiya and also these two experts. So points well taken, and thank you so much, Saraiya madam, from bottom of my heart and on behalf of ICOG for coming to this ICOG Guru Mantra web series program and enlightening our students, fellows and members. And thank you both the experts, Dr. Bhagya and Dr. Shalini, and of course to Sarita and Sheila. So thank you so much, and thank you all the audience for logging in and learning from Guru's Guru. Thank you all.
thank you so much.
Thank you so much.
So
So
Thank you.
Great hearing.
Thank you, everyone. And we look forward to seeing you at the next episode of ICOG Guru Mantra, which is going to be on the 18th of May. And this time we will be focusing on a different area, fetal medicine. Thank you. I think, Nilima, are we offline?
Yeah, Nilima, you can, Mitali, you can stop recording.
Yes, ma'am.
Yes, you can end the meeting also. So see you all next time. Bye.
Thank you so
Thank
much.
you. Thanks a lot.
Thank you.